Welcome back, guys, to another episode of Healthy Design. We'll talk some more about cholesterol today. So, again, keep in mind this is not to be considered medical advice, it's just for educational purposes and to give you some information. Today, we'll talk more about that thrombogenic hypothesis, explain it in pretty good detail, and then, some things that kind of support it. And so, the basic idea for the thrombogenic hypothesis is that there is some damage that occurs to that endothelial, that inner lining of the blood vessel. The body responds appropriately, patches that up, and then that leads to a plaque. Um, there are some people that believe the plaque is basically just a blood clot. When they've looked at it, even from back in I think 1850s on, they see a lot of different things in the plaque and it looks just like a blood clot. And so one way to kind of think about it is like when you were a kid and you scraped your knee would scab up and then the scab fall off. It's basically that kind of same idea. Now in the blood vessel, we don't, again, we've got that blood vessel, we got that inner lining. We don't want something to happen here and then break off and travel, because that could definitely clog things up in a smaller artery, and then we're going to have some different issues where there's going to be blood flow that's not getting in there. So that's not the best way to do it. That'd be more dangerous. So the body has a different way of doing it. But right before we get into that, let's back up a little bit and get a little more science with the blood vessel. So again, we got the blood vessel. That inner wall is the endothelial layer, and that's just a single cell layer thick, and it's very much like our gut. And so there's again, that's only a single cell layer thick, and then there's these tight junctions between the cells in our gut and those endothelial cells. And that's a good thing, because we don't want just anything passing through there. If it's passing through our artery walls, your blood vessel walls, if it's passing through our gut, then it's out in the body. That's going to probably lead to an immune reaction and probably us not feeling that great. So we don't want that. We want some tight control there, pun intended. So what happens in this case is that there's something that will damage the endothelial. So I guess first I should say, because of those tight junctions and everything too, LDL can't pass through that endothelial cell layer. So it can get into that or through that endothelium to then create a problem. And LDL is not a huge molecule or particle, but there are other things floating around in our bloodstream that are even smaller and can't get through that endothelial layer. So it doesn't make sense that something even bigger than those would. There's pretty tight controls that the body has, and it wants to keep things the way it should be. That way we stay healthy, we stay protected. So some of the assumptions just don't make sense. Okay, going back to that thrombogenic hypothesis. Something happens that damages the endothelial cell layer. And one thing to kind of back up, I'm sorry, I keep backing up. In front of that endothelial layer is actually this structure called the glycocalyx. Malcolm Kendrick refers to it as like a little forest right there before the endothelial layer, and that's a protection for it. So it just kind of helps to keep things from being able to attach easily to that endothelial cell and create issues and things too. That glycocalyx can be damaged by high blood sugar levels, insulin resistance, different things like that. So there are things that can damage the glycocalyx, and then that's going to mean that there's more likely to be damage that can occur to that endothelial cell. So, all right, something happens, glycocalyx is not able to protect, endothelial cell layer that gets damaged. Well, then the body responds with an immune response to patch that area up. And basically it creates a clot. So you're going to have a lot of different things in that clot. There will be cholesterol, so what you tend to see are like cholesterol crystals that aren't just floating around in the body, but you also see your red blood cells. Basically anything that's floating around in the bloodstream, you see some of that in a blood clot. And that makes sense. That's kind of the way the body works. I mean, it's similar when you have a scab or something like that. So in this case, one of the things that goes there first to patch up that area of damage is lipoprotein little a. And what lipoprotein little a is, it's actually an LDL with apoprotein A attached to it. And so that protein actually tends to kind of go and patch up that area. It's kind of like if you had a hole in your sheetrock and you spackle it, patch the hole, it's doing that same thing. It's not, it doesn't easily come off. It actually has some different properties to it that help to keep it from being undone by different things to kind of break up clots, because we don't want that coming off just easily, because then it would expose that damage again and then we got to repeat the process. So LPA will go there, kind of patch up the site. Other things will come in to do what it needs to do. And so now we've got this kind of bulbous issue going on. And so it is protruding into that inner cell layer. So from that endothelium, it's protruding into the blood vessel. And so then there are actually these endothelial cell layer progenitor cells that will go to that area and they kind of cover it up. And so that's why we don't see just this blood clot that's hanging out there. And that's a good thing, because again, if we just had a blood clot hanging out there, if it got torn off, then it's going to travel and create different issues. And so what some of the researchers who have been looking at these things, they say that the plaques look just like blood clots, and they look like blood clots in different stages of repair. And some of them will say too that they see basically what looks like kind of the ring structure you see on trees. And so as you have that bulbous area there, those progenitor cells will kind of form a new endothelium, and then the body will kind of shave that down so it's not protruding as much. Of course, there could be more damage that occurs, and then it's going to protrude out, and then hopefully get shaved down some, and that process will just keep repeating. That's part of the healing process. That's part of what we want. And so that seems to be, or that makes more sense to me about how things work, that there's some kind of issue there first. Because again, if you look at least a few years ago, I'm not sure what the risk calculator is now, but the most common risk calculator for heart disease, heart attack that was used in Europe was the Q-RISK-3, and it actually it had 20 different things, but LDL wasn't one of them. Now it did have total cholesterol HDL ratio, so you could make an argument if you want that includes LDL, but it did not have LDL as a risk factor in and of itself, and that's kind of what the diet heart hypothesis is. It's all about LDL. And I should go back, I do like the lipid panel, so total cholesterol and different things, but I like it for different reasons. I think it tells us much more about the metabolic health of a person, rather than being too concerned about total cholesterol levels, LDL, etc. And what they found with research too, the two things on there that tend to correlate more strongly with heart disease, heart attack, is that total cholesterol to HDL ratio, and then the triglyceride to HDL ratio. And we know how to change those things, and it's via diet, so that's a good thing. There is hope. You don't necessarily have to have a medication. So let's go back. And again, they've been researching these things for a long time. And now, do we have any support that would maybe go with this thrombogenic hypothesis? It's had different names over decades, but there's always been a different thought process on what's going on rather than just that diet heart hypothesis. So one of the probably biggest things that I think helps support it is there's a genetic condition called familial hypercholesterolemia or hyperlipidemia. And these people have a genetic issue that's going on that actually leads to extremely high levels of cholesterol and LDL. And I remember when I first learned about this that they were at an increased risk for heart disease, stroke, different things like that, up to a certain age. I don't remember now if that age was in the 50s or 60, but once they got to that age, their risk was basically the same as everybody else. And that never made sense to me, because I'm like, okay, their cholesterol doesn't go down once they hit, let's say, age 60. Their LDL doesn't go down once they hit age 60. None of these other things go down. So why is it that their risk all of a sudden is not the same anymore? It goes down dramatically. And there's different research now that shows the people that have familial hypercholesterolemia, if they have a clotting disorder as well, so they're more likely to produce clots, they have that higher risk for heart disease, heart attack, stroke, different things like that. If they don't have those clotting issues, their risk is basically the same as everybody else. Might be just a little bit higher, but we're talking very, very little, so it's kind of noise. Some other things too with the heart attacks, there's actually around half, I think it's just a little bit over half of the people who have a heart attack actually have low cholesterol levels rather than high. Now, it's not a big difference by any means, so I'm not trying to say that proves anything, but you can't just say, oh, well, it's all about high cholesterol, high LDL, when half or more of the people actually have low levels. And a quick search, I think it was like 75% of people definitely don't have dangerously high levels. So I mean, 75% of people having heart attacks and strokes have either kind of borderline high to low levels, and that's where we're seeing these issues. So again, with the familial hypercholesterolemia, it looks like if there's not an issue with clotting, then they have the same risk as any normal person. And some other things that like Malcolm Kendrick has talked about in his book and on different podcasts, there was a case study written about a child that had sickle cell. And in that too, it kind of supports this blood vessel wall damage hypothesis because the red blood cells are shaped kind of like a sickle, and so they can kind of damage that blood vessel wall. And this child, so for a lot of times you don't see any kind of heart disease or anything in people that have this because unfortunately they don't normally live very long. Luckily that's changing now because things can be done to help out. But so this kid, I don't remember what age he was, but like not even a teenager, and he had severe damage and plaques in like every blood vessel, every artery. And that he didn't have high LDL or anything else. So and when you look at it, there's a lot of times I think with sickle cell it's actually low LDL. So again, that doesn't kind of support the higher it is, the more likely you are to have anything, and getting down to zero is better. Again, we know getting down to zero is not better because you wouldn't live. You need cholesterol, you need LDL. Every cell in our body needs it, and cell membrane, different things like that. So it's very healthy for us to have it. Some of the other things we see, there will be some research that will show that LDL is problematic if it coincides with insulin resistance. And my thinking on that is that we also know from research that if you have insulin resistance or are diabetic, you're more at risk for heart disease. And so is it truly the LDL combined with the insulin resistance that's the problem? Or is it just that insulin resistance is the problem? And that's what we need to address and really not worry so much about the LDL. So that tends to be where I kind of go. I think insulin resistance is the issue. That's definitely one of the big risk factors for heart disease. So we know if it's there, you're at higher risk, whether you have high LDL levels or low LDL levels or even normal. So again, I think we want to address those things. And smoking is another thing that we know has a big risk for heart disease. And not everybody who smokes is going to have high LDL. So again, we see where smoking can release microparticles that end up damaging that endothelial layer, and then the body's going to respond and clean that up. And so one of the things Malcolm Kendrick mentioned is researcher looked at, did some research and found there were these different little like fibrin layers or just fibrin remnants left kind of throughout the vascular system. And fibrin's one of the things that helps us to produce a blood clot, kind of helps bind things down pretty tight. And that's again part of what's going on with the plaque. And so what happens is our body will kind of deal with these things, heal them up, and then that fibrin remnant may be left. And so I think just to kind of give people some hope is, our body's got ways to deal with things. It's a whole lot smarter than we are. And so as long as the damage that's occurring, we can't go through life and not have any damage or any insult, any injury. It's not going to happen. But luckily our body has ways to deal with that. And so as long as the rate of damage and the pace of damage doesn't outpace our healing ability, then we're fine. And once we start having more and more damage and our healing capacity can't keep up, that's when we're going to start to have more issues and things will become more problematic. So that's a little bit about things today. I try not to get too much into the science. There's a whole lot more involved science explaining exactly what happens with a blood clot. But I thought that would be kind of a good base for you guys. And so I do think that LP little a being there is part of the reason why people think LDL is a problem, because again, if you're not looking for that protein attached to it, then you're going to find LDL there. And it's easy to come to that conclusion that it must be the problem. But again, taking a step back, why would the body produce this molecule that we need for life, but yet if we have way too much of it, it's going to kill us? Um, I do think there's plenty of times where we need things in a middle ground. We don't need too much or too little. It can be problematic. So I could see the same thing with LDL. But again, if it was as deadly as people say it is, why would our body need it in the first place? Some other interesting research with LDL2 is we see, especially in women, that as they get older, the higher their LDL and higher their cholesterol level is, the longer they live. It's not this huge difference. I'm not saying like 10, 20 years. But again, if it was so disastrous and deadly, how come they're actually living longer? And we tend to see like a higher all-cause mortality and dying at earlier age with very low levels of LDL versus high. I guess I do want to go ahead and talk a little bit about statins. So these are the drugs that are used to treat high cholesterol, and they do bring down LDL. Changes in diet can bring LDL down some, but tends to pale in comparison to the statins. And so then if this makes such a huge difference, we should see longer life, decreased risk, all these types of things. We don't really see that. There's a website you guys can check out. It's called thennt.com. NNT is for number needed to treat. And you can type in statins and it'll look at different things. And so one thing I should say too, a lot of this is based on industry sponsored research, and they actually won't give that information, that data out to people so that they can independently verify it. There have been some studies done that weren't through the industry, but it's very few compared to how many have been done in the pharmaceutical industry. And so what you see with some of that research is they'll look at different things for primary prevention. So that means preventing the first heart attack. And on that, you really don't see any benefits. It's, 100 to 200 people have to take the statin every year or every day for 5 years for it to prevent like one. Hey guys, let me interrupt. I did look up the NNT to get the specific numbers for you. Actually, I recorded this before and it got erased, so that's why this one came out a little late, but here we go. So if someone has a low risk of cardiovascular disease, if they take a statin every day for 5 years, there's no mortality benefit whatsoever, so that means they won't live any longer. And you need it for 217 people to take the statin every day for 5 years to prevent one non-fatal heart attack. 313 people to take it every day for 5 years to prevent one non-fatal stroke. And let's see, 1 in 21 people, so 21 people take it every day for 5 years, one will have muscle damage, and then 204 people take it every day for 5 years, one will have type 2 diabetes or develop type 2 diabetes. So heart disease prevention without any known heart disease, again, there's no mortality benefit. You'll need to have 104 people take it to prevent one heart attack. 154 people take it to prevent one stroke. And if 50 people take it, one will develop type 2 diabetes. And if 10 people take it every day for 5 years, one will develop muscle damage. Again, all these numbers are taking it every day for 5 years. That tends to be the range. So someone with known heart disease, this is where there is some mortality benefit. So if you have 83 people take it every day for 5 years, it'll save one life. If 39 people take it every day for 5 years, you'll prevent one non-fatal heart attack. If 125 people take it every day for 5 years, you'll prevent one stroke. And again, if 50 people take it, one will develop type 2 diabetes. 10 people take it, one will develop muscle damage. So again, there's still some risk, that's for sure, but at least there is a little bit of benefit with the known heart disease. So that's basically someone who's already had a stroke before. For acute coronary syndrome, which is just a sudden reduction or blockage of blood flow to the heart. Um, there was no benefit whatsoever. None were helped in any manner. And it said an unknown number were harmed. I don't know specifically what that means because that's all it said. But there's at least the specifics on statins for you. This is not meant to make a decision for you. It's just meant to give you information so that you can make the best decision for you. And that's how we kind of need to look at things. We need to look at the costs, we need to look at the benefits, and then hopefully the benefits outweigh those costs. Then it's a good thing to do. If the costs outweigh the benefits, probably not a good thing to do. So everybody's situation is going to be different, but this way you have some information and you can make the right choice for you. All right, back to the other part of the podcast. Now, when we get to secondary prevention, so someone who has known heart disease, has already had a heart attack, then I think it's like 1 in either 50 or 80, I don't remember off the top of my head. But so, I mean, that does help out. But again, we need 50 to 89 people to take the statin every day for 5 years to prevent one. So it's not that each one of those people is going to prevent one. It's only one person out of whoever's taken it for 5 years will have that prevention. And so again, with that too, for people with known heart disease, I think the overall life extension is like 4 days, 4.1 days. So it's not a huge difference by any means. And then some of the other things they found with research that was done outside of the industry is that a lot of people don't end up taking the statins for even 5 years. A lot of people, not all, but many people will stop beforehand due to different side effects. And so, you know, it's like 1 in 10 and 1 in 50 will have muscle damage, or will become diabetic due to it. So those are some of the side effects. And, you know, especially we don't want the muscle loss because as we get older, that muscle tends to be correlated with longevity. I think it's just we tend to be healthier if we have more muscle. Don't think the muscle itself is doing something. And then with the diabetic side, if we are diabetic, we know we're at increased risk for heart disease and stuff too. So it's kind of, I don't know. I wonder if that balances out or if diabetes keeps getting worse, it just kind of overrides any benefits. And what some people theorize and think is that the statins, yes, they do lower LDL. That doesn't seem to explain their benefits. What they also do is they decrease inflammation and they decrease clotting. And it seems like inflammation and clotting are playing a bigger role in heart disease, heart attacks, and strokes than LDL. So that's information for you guys. Like I said, I would check out the nnt.com. Sorry, I'll get that right. It's got good information. It's easy to understand because you can just see it tells you like the number you need to treat. So, you know, let's say you have to treat 200 people every day for 5 years to prevent 1 X. And so we'll just have it listed that way for you. So it's easy to see, and you can see it like for primary prevention. So people without known heart disease, for people with known heart disease that have had an issue in the past, and it just breaks it down. And so I think it gives you more information so that you can decide what's best for you. I'm not here to try to tell people they should do one thing versus another. I think what we want to do with everything is, again, kind of follow those foundations of health so we kind of put our body in the best place we can so that it can deal with things and, you know, respond the way it's supposed to, and us kind of get out of the way. And then if we need medication on top of that, that's fine. But I think we need to know the information. We need to know the risks. We need to know the benefits. And so I don't think a lot of times with the statins, people know the risks that, you know, there is that muscle pain, muscle damage that occurs. Some people will complain of dementia. There's a famous astronaut, he took statins and ended up with dementia-like symptoms, went off the statin, everything cleared up. Tried it again, same thing happened, went off of it, cleared up. And I've seen that with a few people as well. So keep those things in mind. Just know what the risks are, know what the benefits are, then you can make the best choice and what's going to be best for you. So hope that was entertaining, hope it was interesting. That might be the end of this cholesterol series now. I'm sure we'll touch on it again in the future, but that's probably enough at this point. I think it definitely covers all the main things. But if you got questions or anything, leave a comment, let me know, and I will answer it as best I can. Thanks, guys. Have a good one. Bye.